California Improvement Network. Today's webinar is entitled Reducing Waste with High Value Care, and we will hear about the American College of Physicians online training program designed to train providers to weigh the benefits of a given medical intervention against its costs and risks using interactive case studies. We'll also hear how this program is being used at a pilot site in New Jersey. We are joined today by Dr. Daisy Smith, a senior physician educator at the American College of Physicians, and Dr. Steve Peskin, Senior Medical Director and Director of Clinical Innovations at Horizon Healthcare Innovations, Horizon Blue Cross Blue Shield of New Jersey. Before we begin, just a few housekeeping items. You should see on your screen a brief poll for participants. If people wouldn't mind answering the questions that they see, it just gives us a better sense of who's in the audience. And at the end of the webinar today, I'll be asking for feedback with a very short survey. So if folks wouldn't mind taking in just a minute to answer those questions, we'd really appreciate the feedback. The session today will be recorded. The slides and the recording will be posted on the CIN website, which you can see on the slides above, in about a week. Speakers today will talk for about 40 to 45 minutes, so we'll have plenty of time for Q&A. If people have questions, they can use the chat box on their screen to send questions to the hosts. If you have a question a logistical question about something being an issue, please just send your question to the host only. But if you have a question about the presentation, you can send the questions to everyone so that everyone can see the types of questions that are there. So today's speakers, we are joined by Dr. Daisy Smith, who's a senior medical educator at the American College of Physicians and an adjunct associate professor of medicine at University of Pennsylvania. She received her MD degree from the Columbia College of Physicians and Surgeons and is board certified in internal medicine and a fellow of the American College of Physicians. Since joining the American College of Physicians, she led a group of educators in the development of the high-value care curriculum for internal medicine residents, which has been downloaded over 19,000 times since its launch in 2012. And her current responsibilities at the ACP include supporting the high-value care initiative, the internal medicine in training exam, the Waxham Clinical Skills Center, the medical knowledge self-assessment program, and creating new educational products for medical students, residents, faculty, and practicing physicians. And she continues to see outpatients and teach medical residents at the University of Pennsylvania. We're also joined today by Dr. Steve Peskin, who's the Senior Medical Director at Horizon Healthcare Innovations at Horizon Healthcare Services Incorporated. His expertise encompasses physician leadership, medical delivery management, performance improvement in healthcare, and payment innovation. And Dr. Peskin's primary responsibility at Horizon Healthcare Services focus on the patient-centered medical home program. And he leads the collaboration to improve population health, enhance patient experience, and mitigate the cost of care. And he also works as part of the leadership team that is advancing provider payment innovations to reward value versus volume. He received his bachelor's degree from the University of North Carolina, Chapel Hill, and a medical degree from Emory University School of Medicine. He completed his residency at St. Elizabeth's Medical Center in Boston and holds an MBA from the Sloan School of Management at MIT. So with that, I will hand it over to Dr. Smith to begin today's presentation.
Good afternoon, everybody. It's my pleasure to be talking with you about our High Value Care initiative, and I'm hoping all of us can work together to promote the making of informed decisions, reducing waste, and improving patient outcomes. I just want to start with the disclosure slides. So I am salaried by the American College of Physicians, and my husband is a medical researcher at Merck, so I have stock and stock options in that company. We'll go on to Steve Peskin's disclosures. So he is salaried by Horizon Blue Cross Blue Shield of New Jersey. Next slide. So these are the learning objectives. Hopefully at the end of our time together this afternoon, all of you will feel comfortable defining high-value care and what we mean when we say that, because it's kind of a vague term. You'll have a better understanding of provider-driven sources of excessive healthcare costs You'll feel comfortable explaining the framework and the guiding principles behind the High Value Care Initiative. You'll feel be proactive about identifying care that provides no benefit and may be harmful to patients. And finally, you'll feel empowered to overcome some of the barriers to high value care, which are outlined here. So I'm going to start by introducing the initiative. Then I'm going to show the online high value care cases introductory video because it kind of sums up a lot of the stuff that I was going to say anyway and that I usually say, and also gives you a peek at what the online high value care cases look like. I'm going to demonstrate a sample case with the 2 questions that go along with it. And then we'll spend a little time going through the pilot feedback because with the help of the California Healthcare Foundation, we did pilot this program to practicing physicians over the summer and got some interesting results. And then I'm going to turn it over to Stephen to talk about some of his challenges in the state of New Jersey and how he thinks he might utilize this program in his state. So we'll start with the definition of high value care. This is care that clinical benefit of the clinical benefit of a medical intervention with the costs and harms with the ultimate goal of improving patient outcomes. And this is the timeline of our initiative. We launched the initiative initially in 2010, actually before I joined the college, with the policy paper that was published in the Annals of Internal Medicine. There were several guidelines papers that came out, and in 2012, we collaborated with the Alliance for Academic Internal Medicine to create a free, sort of off-the-shelf, high-value care curriculum for internal medicine residents that Lori mentioned in her introduction, which has been downloaded over 19,000 times. 20% of the downloads, interestingly, are from the learners themselves. So that's, we can tell that the younger generation of providers is really interested in this topic. In 2013, we launched our high value care website where all of these materials are free to the public and are all housed in one site to make it easy for you all to find them. And then just earlier this month, we launched these online high value care cases, which I will be telling you more about in the coming slides. So now we're going to shift gears and go to the introductory video. It's a little under 6 minutes, and it will introduce you to this new program. Hello, my name is Dr. Daisy Smith, and I'm a Great. Well, thank you guys for sitting through that video. I thought it would be better doing this on a webinar. The last time I showed the video, I was actually speaking, and it was incredibly awkward to be standing there at the podium while you were showing a video of yourself. Anyway, thank you for watching that. I wanted to now delve down a little bit deeper into the program. You've watched the introductory video. There are 5 topics. The topics that we cover in the program include topic 1, avoid unnecessary testing. 2 focuses on how the setting of care affects costs and how providers can use emergency and hospital level care judiciously. 3 is focused on improving outcomes with health promotion and disease prevention. 4 is focused on high-value medication prescribing. And 5 is focused on overcoming barriers to high-value care and focuses a lot on communication tools. Each one of the modules has take-home tools, which are pretty much a combination of patient education materials that are on the topics that are covered in each of the modules. So this is the first topic, and which is avoid unnecessary testing, and these are the 3 learning objectives for topic 1. The idea is to train providers to use validated decision support tools to increase diagnostic accuracy and also diagnostic efficiency, to practice estimating harms and costs associated with common tests, and to balance benefits with the harms and costs of testing. So here's our first patient. This patient was actually in a hospital in California. The pictures are real people, but not the actual patient. But this is a patient and her hospital bill from I will not say the name of the hospital that she came from in California. So Michelle Barrow is a 59-year-old woman, 3 days after having a laparoscopic cholecystectomy, who was walking with her physical therapist, and she complained of acute onset shoulder pain and shortness of breath. You're called to see her, and on physical exam, you see that she's sweaty, she's afebrile, her blood pressure's a little on the low side, her heart rate's up at 115, her respiratory rate is up as well, and her oxygen saturation is low. Her lungs, she has some crackles at the bases that clear with coughing. Her abdomen, particularly her surgical site, is benign, and she has no other findings. Her portable chest x-ray just shows atelectasis. So based on your assessment, you think that she might have had a pulmonary embolism or a blood clot to her lung, and you calculate her pretest probability using the Wells score. Her score is 6, which means she has between a 16 and 20% chance of having a pulmonary embolism. So the first question with this case is, given Ms. Barrow's high pretest probability, which of the following tests is the most cost-effective for diagnosing pulmonary embolism? And there's a list of questions, and the providers need to select the correct answer, which is pulmonary CT angiography. After they select the answer, it will turn red if it's wrong and green if it's correct. But then they get the key point of the question, and the key point here is in patients with high pretest probability, pulmonary CT angiography is the most cost-effective diagnostic test. And then there's an explanation, and the explanation here goes through how to use validated risk scores to guide testing. It talks about why the correct answer is correct and why the incorrect answers are incorrect, and goes through all the options on the list. Then it teaches some general principles, and this is a key principle here, which is that value is not equal to the cost of the test. High-value care is not always choosing the least expensive test. High-value care is making the correct diagnosis as efficiently as possible and avoiding unnecessary testing and delaying treatment. And then it talks about some of the other options on the list and why they may not be correct. So we get back to our patient. Ms. Barrow is stabilized and transferred to the ICU. Her pulmonary angiography confirms the diagnosis of pulmonary embolism, and she's given intravenous heparin. Her subsequent course is uncomplicated, and this is her hospital bill. So the bill is organized so that all the laboratory testing is along the left-hand side of the slide. The meds are in the upper right-hand corner, imaging studies are in the middle, and provider costs are at the bottom. I should say this isn't her entire hospital bill because none of her surgical charges are on it. This is just the bill when she came to the medical service. So it's just under $30,000. So question 2 actually forces the provider to take a look at the bill and really analyze it. And the question is, which of the following categories of services that Mrs. Barrow received contributed the most to her charges with the least clinical benefit? And you can see the 4 categories of charges. So not surprising, I'm sure to many of you on this webinar, imaging studies is a huge driver of overuse. And when you look at Medicare recipients and growth in different services over the past 10 years, imaging and laboratory testing have really outstripped all other services for patients. And this is also accompanied by the key point, which is that diagnostic testing should be tailored to the individual patient and focused on making an accurate diagnosis as efficiently as possible. And the critique also highlights that this patient, in addition to all the money that was wasted on unnecessary imaging studies, there was quite a bit of money that was wasted on unnecessary laboratory investigations as well, and that this totaled $6,000 in unnecessary testing. It goes on to talk about how she had a straightforward diagnosis, identified and treated quickly, but still she had this extensive workup. And the focus really is on individualizing the care and not providing one-size-fits-all medicine. So I'm going to shift gears now and talk about what the providers who went through all of these topics, what their opinion of the experience was. We piloted this to a group of busy clinicians in order to participate in the pilot study that we did this summer. The providers had to spend over 50% of their time in clinical practice, and we had about 30% agree to participate, and of those 65% completed all 5 topics, and the vast majority also did the survey. So it seemed like going through the program significantly impacted at least their self-reported behavior. Physicians increased the frequency of discussing risks and benefits with patients and also discussing relative costs and offering alternatives. In addition, they decreased the frequency of ordering unnecessary tests and treatments because they were requested by patients or because they were afraid of malpractice. In addition, it seemed to bolster their confidence in how to communicate with patients about why tests are not necessary. I mentioned that there were some video content, and there are videos included in the critiques that help role model how to have this discussion. And you can see if the gold bar is before they went through the program and the bluish bar is after, you can see that we almost doubled the number of providers who were very confident in communicating with patients this way. And we also asked about impact of the program on their motivation to incorporate principles into daily practice. And you can see here over 90% of the providers who went through the training felt either somewhat or very motivated to incorporate these principles into their practice. So we were really pleased with these pilot results. We did get a lot of constructive feedback about the cases and the questions which we incorporated into the program that we launched earlier this month. So shifting gears now, I want to talk about, obviously we can't just work on engaging providers, we need to work on engaging patients. And on a sunny Saturday in April last year, we did our first Patient Empowerment Expo on high-value care. We had over 450 patients from the Bay Area. We worked with our partner Consumer Reports to help recruit the patients, and the Discovery Channel was also a partner in this fair. And I was lucky enough to be invited to be a speaker, and we had such a rich discussion. I think the question and answer session was one of the best that we've ever had. And what I came away from that experience with was the idea that patients are ready and eager to really talk about these issues, and they want to be engaged in it. We are doing another Patient Empowerment Expo on high-value care this April in conjunction with our national meeting in Orlando. We also, as I mentioned, partnered with Consumer Reports and have partnered with ARC to provide some patient educational materials. And we have a new Center for Patient Partnership and Engagement at the ACP, and we are working very closely with them to create complementary materials to educate providers and patients/consumers with a consistent message. So as we develop these and they come out, they will also be freely available to the public from our website. So I would urge you to take a look at the website if you haven't already been on, to take a look at these materials. And a lot of the stuff I've mentioned so far has been focusing on the low-hanging fruit. I think there's a lot of work to be done looking towards the future for more into deeper waters, but right now we really want to focus on getting rid of the waste. We have some good partners with this. Hopefully many of you have heard about the ABIM Choosing Wisely campaign. Over 52 medical societies have published lists of 5 things that physicians and patients should question. These are evidence-based lists and have really been wonderful in starting the conversation about how we can all be better stewards of limited healthcare resources. These lists are publicly available, and they have a nice collaboration with Consumer Reports to translate these lists into patient education materials. We are working on expanding our initiative. We just got grant funding to expand this into the medical student space, and I've had several very promising calls and meetings with folks from other specialties who want to adapt our materials and put in cases that are more specific to their specialties, but keep the underlying definition and foundation and framework. So we're trying to expand beyond internal medicine. But we have some challenges ahead. End-of-life care, we still have not really addressed in any of our educational materials. And then there are a lot of external forces. We did try to address some defensive medicine, but misaligned financial incentives are a big thing, physician financial conflict of interest, and overpricing and price transparency. Those are all other things that we may need to take on in the future, if not from an educational standpoint, certainly from a policy standpoint. So in summary, what can we do? ACP has developed a library of free tools for providers and patients to engage them in the initiative, and we need your help to get the word out to providers to use these tools. And I'm an optimist. I think that if we work together to motivate and engage providers and patients in solving these problems, that we will absolutely succeed in what we do. So I want to pass the baton over to my colleague, Steve Peskin. I met Steve in San Francisco last April when I presented some of this material to the ACP governors. In addition to his role at Horizon Blue Cross, Steve is also the ACP governor for New Jersey. So without further ado, I will pass this baton on to Steve and have him go through his slides.
Thanks, Daisy. Appreciate it. And where is the baton? The slide advance. Hello? Can you hear me?
If you click the arrow at the top right, you can advance the slides.
Let's see.
I'm going to see if I'm doing it. Here you go. I'll just advance them for you, Steve.
Okay, thanks. Thanks. So thanks so much.
If you could pass it back to Daisy.
Okay, great, great. So we've been at this for about 3 years. Well, Horizon in business in New Jersey for 80 years, and I really feel not worthy kind of preaching to the converted here. In California, I mentioned on the phone just before we got started, at some years with Pacific Care Health System, so have some familiarity with California and a lot of advances in collaborative care models and in sort of appreciating the total cost of care and so forth, but something that hasn't been much of an attention in New Jersey until late. So you can see we don't rank that well, 42nd Dartmouth Health Atlas on quality and 48th in value for care. So Houston, we do have a problem. Additionally, confounding that is Primary care physicians, clinicians are generally less well compensated in New Jersey than other physicians, and difficulty attracting and retaining physicians to do the important work in primary care. So that was the situation. About 3 years ago, again, we started in earnest toward working with clinicians in a highly collaborative way on the quest for value. And in doing that, we embrace initiatives like Choosing Wisely from the ABIM Foundation and the great work that the ACP is doing its High Value Initiative. So next slide. So we've looked at 5 really guiding principles, certainly payment reform, where we pay for value versus volume, population care coordinator. Really, these individuals are the embodiment, but it doesn't just begin and end with registered nurses that we were involved in training with the curriculum that we developed along with the Duke School of Nursing and the Rutgers School of Nursing on care planning, chronic condition management, longitudinal tracking of patients with chronic conditions. But really getting everyone invested and involved, the primary care physicians, the advanced practice nurses, the medical assistants, allowing individuals to operate to the top of his or her certification or license. So really people have more joy in the work that they do, physicians, medical assistants, nurses, the front office staff, and practices involving, as we call it, and I'm sure you've heard the notion, the medical neighborhood, so our subspecialist colleagues. We do a lot of, and really where we focus today, this notion of a learning network, learning collaborative, where we really leverage great work like the High Value Initiative that Dr. Smith talked about so eloquently. So we have other tools that we've developed that show practices if they don't know what a care plan is or what the value of a huddle visit is, representation of different responsibilities that individuals can participate in, and that really involves a lot of shared learning where it's not simply Horizon or our Lean Six Sigma trained folks going out and talking, but people who have walked the walk and really using our value-based partners to mentor one another. Certainly there's a lot of ongoing need for data and technology integration, so we work very hard to provide actionable, relevant, timely information for the marrying up of claim data from our systems and importing using information engines, information exchange with our practice partners from their electronic health records. And very importantly, the notions of engaging and educating and empowering patients. And again, Dr. Smith, Daisy talked about that as part of how you have those conversations with patients so that they really appreciate that there may be not only cost, but consequences involved with low value or unnecessary diagnostic tests where they may have a preconceived notion that that's, I want that fancy scan, doctor. In fact, I still see patients one afternoon a week, and was having this very conversation yesterday as the snow was falling hard in New Jersey with a woman and her daughter, along with the resident, looking for having a second abdominal CT scan, where really the first one wasn't necessary, and certainly the second one was absolutely unnecessary. And I think the next slide might be my last slide, Daisy. So just talking about what we do as it relates to payment reform. We do, in our basic model, we do provide outcomes-based payment in addition to fee-for-service continuing for the CPT codes, although moving away again from an inexorable, just increasing fees toward really modulating that and providing clinicians with incentives for outcomes-based payment, which are based on quality and efficiency, sort of quality up the y-axis and efficiency across the x-axis. And here you just see some representative examples. The superimposition is where the practice started in their prior year. So if they were less efficient as they began the journey with us, their opportunity is lower, whereas if they were the most efficient above the 75th percentile, their opportunity is greater, but of course they've set for themselves a relatively higher bar to begin with, which is where a lot of the systems are already in California. So again, bringing it back to Daisy's front end, we involve things like the High Value Initiative in our curriculum. We're constantly looking for better ways, whether it be from the Institute of Health Improvement or AHRQ or ACP or the American Academy of Family Physicians. We certainly don't have a not invented here syndrome, and leveraging the good work that's being done in other parts of the country by professional organizations, by research-driven organizations to really give our value-based partners the tools and the information that they need to practice more cost-aware or high-value medicine. So with that, I'll wrap up my introductory comments, and I think we've left about 25 minutes for conversation.
Great. Well, thank you very much both for your presentation. We've got a couple questions to kick things off, but if people have additional questions they want to send in through the chat box, we definitely have some time for a couple more. And also just a reminder that the slides will be posted on the website, and for anybody who had trouble hearing the audio, the link was posted in the chat function, but also will be within the slides. So again, a couple of questions. So first, can you just speak a little bit to how we can incent providers to complete this training program?
Sure, I'm happy to take that question. So I did mention in the introductory video that these are a wonderful source of free continuing medical education credits, including patient safety, CME, as well as we just recently got free ABIM maintenance of certification points, including patient safety MOC points. So it really is, we're hoping that those two things will drive providers to want to use these products because they need these types of credits to maintain their state medical licenses. I think also our goal is to really start engaging patients more and more in the initiative and encouraging them to have these collaborative discussions at the bedside with their providers. And we are in the process of developing some companion patient educational materials to train and motivate them to engage in these discussions with providers too. So I don't know, Steve, if you have any thoughts on how to motivate providers to complete the online training.
Yeah, we really, we see our role as involving and motivating physician champions. Those individuals in their practices will have an ability to cajole, promote, suggest, recommend, mandate that clinicians, advanced practice nurses, PAs, physicians in their organizations avail themselves of great stuff like this. We have it's not really an incentive necessarily, but we do routinely webinars and programs where we'll profile things on things like the prescriber order or practitioner order for life-sustaining treatment. Dr. Smith had end-of-life care as one of the areas that they're going to focus on in the future. So the PULSE form or the ACP high-value curriculum as examples of things that we will showcase on our web seminars, and we generally get good attendance from that. Now, just attending a webinar doesn't mean that the person's going to take the next step, which would be actually going on and doing the program. But we are seeing that ability to create some of the surround sound. Not necessarily if you give it, they will use it, but getting the leaders in the organizations to embrace it and endorse it, and we found that to be very effective.
Great, thanks. So another question, moving a little bit to the reimbursement system, how given the challenge, or given the existing reimbursement system, how do you balance what you're asking providers to do here in light of, in many ways, traditional fee-for-service reimbursement systems, and how do you get around some of the challenges associated with that?
We are very cognizant, and if I've heard it once, I've heard it 10,000 times. The family physicians, the general internist said, well, you know, you're the ones who got me on this hamster wheel, that you're you know, paying me for 99213s, maybe less than they should be. So again, we've changed the payment model to some extent to recognize that there are uncompensated or historically uncompensated services such as care coordination, that we do provide care coordination fees to practices to reflect that time, effort, energy in talking to the hospitalist and talking to the discharge planner and talking to the rheumatologist about an individual. And then the outcomes-based part of it, some of those payments are quite substantial. In our second level of this a shared savings model, there is a total cost of care share of savings, and that total cost of care is also associated with meeting certain quality measures and patient satisfaction, or as it's now called, patient experience.
And I would just say, I talk about this sort of all over the country, and oftentimes this question does come up to me as, you know, well, why are you focusing on what the providers could do when we have so many misaligned financial incentives? And the answer that I often give is that, you know, though the reimbursement system is changing, there's so much heterogeneity across the nation in the rate of that change and what people are doing, but that we really shouldn't wait for the system to change before we start changing our own behavior, and that we should start with ourselves. And the bottom line is over-testing and over-treating patients is causing real physical, emotional, and financial harm, and we should do what we can now to really eliminate these practices wherever we can. So that's the answer. It's not always popular because a lot of times people are saying, well, it makes sense what you're asking us to do, but if we do this, we're going to put our hospitals out of business. So I'm not saying that financial incentives in the reimbursement system don't need to change. I'm just saying we don't need to wait for them to change because our job is, first of all, to do no harm.
Okay, great, thanks. We've got another question if there's anyone else who wants to chime in. We've also posted a poll for feedback up on the web. If folks could just take a few seconds to fill those questions out, we'd appreciate it. But one more question is, in terms of how do you think through, as physicians learn about this behavior and these practices, what about the practices, the ordering practices, other providers in the system, whether that's specialists and or primary care physicians, and how do we work within the system where you've got all sorts of other providers who are contributing to the waste?
Well, that's an excellent question, and one that is often asked. And it's so funny because the way that question is asked really depends on who I'm speaking to. So I went to the liver meetings this year and spoke about high-value care to a very engaged audience. And you know, they asked the question about those primary care physicians. They order so many unnecessary tests and referrals, you know, before they consult me, and they're really driving the waste. And when I talk to generalists, their perception is that the emergency medicine physicians and the subspecialists are really driving a lot of the waste. And, you know, my answer is, first of all, you have to start with yourself and what you're doing, but that there are really constructive ways to open the lines of communication and start talking with the specialists you send your patients to. And, well, I'm a generalist, so I'm coming from that standpoint. You know, I think a lot of these new models, the patient-centered medical home and neighborhood and the ACO model, but I don't think you have to wait until you're practicing within that type of model to open the lines of communication and really sit down and discuss how you want this to come about. I have had the chance to see our ACP Council of Subspecialists attack this problem with creating a toolbox I think there are 4 or 5 different documents in the toolbox to help both generalists and specialists improve their communication and to set expectations around basically high-value consultation and referral. And those tools will be available on our high-value care website in April. But I think, you know, part of it is you have to talk with these folks and you have to negotiate and it's amazing once you start opening those lines of communication. I was in Boston talking about this, and our emergency medicine doctor, you know, raised her hand. She said, yeah, you know, we were getting FK506 levels on all our kidney transplant patients in the ER, and when we started talking with our nephrologist, they said, you know, the random levels don't give us any information. It's a complete waste of money. So once they started talking, they came up with all these synergistic areas where they could start saving money. So part of it is just starting the conversation.
Yeah, and actually another American College of Physicians tool is this collaborative care agreement. So we endorse that, and a number of our practices have primary care practices in the medical home. The typical primary care has 229 other physicians and 117 practices with which care must be coordinated. That's from Annals of Internal Medicine 2009. The average Medicare population person sees 7 different physicians and fills upwards of 20 prescriptions a year, another reference from Hopkins. So really recognizing the importance of that, and as our practices advance along the journey. And to Daisy's point is that it's not just the primary care docs and advanced practice primary care nurses pointing the finger always at the subspecialist, because certainly also being a generalist, we are guilty as charged as well of some overuse, misuse, not getting the subspecialists with the information they need, tests that we've already ordered, for example. Many specialists report that they don't get information. 60% in fact reported not receiving information from primary care prior to a referral visit. So those are some of the things that we work on. Another specific example, a technology that I was just introduced to last week by one of our physician-led ACO partners called Cortex, which allows for secure HIPAA-compliant messaging, and the emergency medicine doc saying that, well, you know, we admit the patients because we're not able to contact anybody, and it may be a flimsy CYA medical malpractice excuse, but they admit them, or they admit them for observation. And so this particular physician-led ACO said, well, we will respond to these Cortex messages, whether it's at 4 a.m. or 3 a.m. or 2:30 in the afternoon. And then the ER doc says, well, okay, if I know somebody's on the other end that's going to see the patient at 8 a.m. the next day, then I'll feel more comfortable not admitting them for observation.
Great. Well, thank you both for a great presentation. Thanks, everyone, for joining today. Our next webinar will be on Wednesday, February 26th, and the topic will be health homes, and we hope many of you guys, many of you can join for that. Thank you all.
Thanks.
Thanks, everybody. Be well.
Bye-bye.